terms of relapsed refractory CLL, it's a diverse array of patients now. So we have patients who are relapsing after chemoimmunotherapy only, and then we have patients progressing after covalent BTK inhibitors or time-limited venetoclax-based therapy. I would say the patients who are at greatest unmet need still are those with high-risk genetics, particularly patients with unmutated IGHV and especially TP53 aberration. These are patients who have a more aggressive form of CLL that tends to relapse sooner and tends to be harder to treat. The other major gap that we have right now I would consider to be Richter transformation, which is when CLL becomes a more aggressive lymphoma, and unfortunately our therapies for those patients are quite poor still. I think one of the greatest breakthroughs in the last couple of years has been the development of non-covalent BTK inhibitors, in particular the FDA and EMA approval of pirtobrutinib. This drug is very active even in patients who have progressed after covalent BTK inhibitors. We recently had a publication of the Bruin 321 phase 3 trial, which compared pirtobrutinib to existing standards of care, including chemoimmunotherapy and PI3 kinase inhibitors. And pirtobrutinib did result in a longer progression-free survival and an impressive time to next treatment of around 2 years. For a very heavily pretreated population with high-risk genetics, I found that to be impressive. We've also recently seen the approval in the US of CAR T-cell based therapy with liso-cel. This is still only working in a minority of patients, but it does work when given in certain contexts, particularly we think in the combination with BTK inhibitors. So I think it is worthy of further exploration, especially for these high-risk patients. I would say overall the data for the real-world evidence is relatively similar to what we see in the trials. If anything, though, in the real-world setting, patients tend to have more comorbidities, they tend to be older, and so the outcomes are somewhat poorer than what we see in clinical trials, which are often selected for patients who are fit enough to go on the trials. At the EHA meeting, we had a poster on real-world evidence for patients who were double refractory and double exposed to covalent BTK inhibitors and BCL2 inhibitor venetoclax. We did find that patients who were double refractory had an even poorer prognosis than patients who were just double exposed. So that's a particular target population of unmet need, and I think the real-world data really highlight that. One of the things that we've seen is that although pirtobrutinib is very effective at inducing response in the majority of these very refractory patients, the duration of that response or progression-free survival is relatively short, only on the order of about a year to a year and a half in this population of double refractory patients. So I think the big question that raises is what comes next for these patients. Pirtobrutinib can be a bridge to other cellular therapies like CAR T or even allogeneic stem cell transplantation in a younger fit population. But most of our CLL patients are older and frailer and may not be candidates for these more aggressive therapies. One of the promising developments is that we've recently seen the development of BTK degrader drugs. There's a couple of them that are now in clinical trials. And it's kind of reassuring actually that we're starting to see responses even in patients after non-covalent BTK inhibitors. We don't yet know how durable these responses are, but I do think BTK degraders are going to be an important part of our treatment arsenal in the future. I think if I look back over the last decade, we've seen so much progress, and I think that it's likely that that progress will continue. One of the things that is exciting to me also is the development of bispecific antibodies in CLL. This is a therapeutic modality that's made a huge difference for other lymphomas. And honestly, I was a little bit skeptical that it would make a difference in CLL based on the immune dysfunction that we know is inherent to the disease. But what we've seen so far in the early data with, for example, epcoritamab, is that about 40% of patients with relapsed refractory CLL who are heavily pretreated will obtain a complete remission to that single bispecific antibody. So it really gives me hope that we could potentially integrate this type of approach, even maybe in earlier lines of therapy, and eventually strive toward a cure for patients with CLL.